Hi, we had a great session today here at the IHF. We had a session on cardiogenic shock, VSD, post-MI, and an hour's worth of discussion from expert speakers. And I've got Antoine here today. Antoine, I wanted to ask you a bit about inotropes in shock in general. Could you give me a bit of an overview about the drugs that you think are useful in the management of shock?
Yes, thank you very much. It's a huge question, so I will make a very quick summary. So first, what is the best choice at the bedside for any sort of cardiogenic shock with a vasoconstricted phenotype? Meaning that the arterial pressure, the diastolic arterial pressure is maintained.
Yeah.
For me, and for most experts, with no formal evidence, there is no randomized controlled trial that tests Dobutamine.
Yeah.
Dobutamine, a beta-1, slightly beta-2 agonists, but it's the best choice at the bedside because the half-life is very short.
Yeah.
It increases the cardiac output, also the heart rhythm, but it's a good choice. If you have to compare it with, for instance, milrinone or levosimendan, calcium sensitizer, type 3 phosphodiesterase inhibitors, there is no proven difference between them.
Mm-hmm.
But at the bedside, the half-life is far more smaller with Dobutamine compared to the other drugs. So
Yes.
This is my first choice.
So you basically, if you have side effects from Dobutamine, what you're saying is because of the short half-life, you have the flexibility of stopping and reversing the side effect. Whilst with levosimendan, for example, once you've given it, you're basically jumping off the diving board, so to speak, because the half-life is so long, you can't, then you have to deal with the after effects.
Exactly. This is an excellent example with levosimendan.
Mm-hmm.
Levosimendan half-life is far more longer. For instance, it will last more than 2 weeks sometimes.
Yeah.
Dobutamine, it's 3 minutes.
Yeah.
What should you prefer as an intensivist at the bedside?
You've got the flexibility of changing it.
Flexibility is far better with Dobutamine than other drugs.
And what kind of doses do you give?
Excellent question. We have to begin with very low dose. 2 micrograms per kilo per minute, down to up to 5.
Okay.
Maximum 8, sometimes 10, but you have to test the dose against the vasodilatation due to the beta-2 effect.
Yeah, and on that point, a lot of people worry about using these inodilators with low blood pressure. How would you manage that? If you had somebody with a systolic of 80, for example, in cardiogenic shock, would you then add another drug, or would you cautiously...
Not on the systolic pressure, but on the diastolic pressure, maybe it's the best.
Okay.
So you have to look to the diastolic pressure at the bedside very simply. If the diastolic pressure is low, very low, I mean 40, 45 millimeters of mercury, I think adding Dobutamine alone will worsen the clinical state.
Right.
Because of the beta-2 effect.
Yeah.
Even if it's small, but also because of the increase in the heart rate.
Yeah.
So for me, you have to add inopressor. Inopressor meaning beta-1 effect and alpha-1 effect, and there is one drug. One first-line agent recommended by all agencies, all regulatories, is Norepinephrine, even if the evidence are quite low.
So that's really interesting. It's not the systolic, but the diastolic blood pressure.
Diastolic.
40 is your cutoff. So if you had somebody with a systolic of 80 and a diastolic of 50, you would be happy to start Dobutamine.
Exactly.
Right?
Exactly.
And that's a really important point. But if the diastolic was lower, how would you kind of deal with that situation? Would you escalate to MCS, or would you be adding in other drugs like noradrenaline?
So
interesting to hear.
First, you have to restore the diastolic pressure. Okay. Before beginning Dobutamine, for instance, Inotrope, you have to restore the diastolic arterial pressure with Norepinephrine.
Right.
Then you could add Dobutamine and inodilator. And then, if it doesn't work, maybe you will have to think about MCS.
Yeah, I mean, it's really good to hear you talk about the use of these drugs because you do this day in, day out.
Yeah.
I wonder if you could talk a bit about levosimendan and where you see the role of levosimendan in cardiogenic shock.
So I have something to disclose. My team is leading RCT, level arc shock, testing against standard care levosimendan. At that time, all the evidence are, to be honest, against levosimendans in any situation: septic shock, pre-cardiac surgery, post-cardiac surgery, for winning ECMO in big journals.
Yeah.
So we are expecting the results in the 2, 3, 4 years because it's a huge study. But now, I think we have to be cautious with the patients, not to harm, and to stay with Dobutamine and not to use levosimendan as a standard of care. Maybe in case of palliative care, it's a good idea to use.
To get the patients.
Yes. To discharge the patients and to patient go back to receive another dose of levosimendan.
So you can give it every 2 weeks,
for
basically,
instance.
and they can be at home.
Yeah, it's a good idea.
And just finally, before we sort of stop, is what are your thoughts on dopamine? I mean, a lot of people and a lot of centers use dopamine.
Dopamine or dopakill, as we say in English, it's a bad idea.
Right.
You should not use dopamine while in patient because there is an important study, the SOP2 trial. It's a whole trial from Daniel De Becker, demonstrating that in the subgroup of cardiogenic shock patients, there is an increased risk of death compared to norepinephrine group, due to, maybe there is no causality, but association with higher rate of arrhythmias in the dopamine group. So no dopamine.
That's a really good takeaway point. So Dobutamine, role of levosimendan, and obviously don't use dopamine. It's been a wonderful session today, and obviously if you want to learn a bit more about cardiogenic shock and management, I'd encourage you to join the full hour session where you'll hear Antoine and other colleagues tell you more about the management of cardiogenic shock.
Thank you very much.
Bye.